Thank you very much for giving me this opportunity to present here. Let me know if you see my screen.
Yeah, it's not quite large screen, Ali. Make it, there you go, perfect.
Yeah, excellent. All right, so I'm kind of piggybacking on the prior lecture. This is like, I don't know, it's a funny coincidence, I guess, that we're talking almost about the same thing, but I would like to just talk about a little bit more in detail about middle fossa anatomy. It's a surgical anatomy. Middle fossa is basically a very complex region in terms of like its anatomical relationships. And for that reason, it seems that many surgeons shy away from some of the approaches that are here. And I guess the most important reason for that is less familiarity with the detailed anatomy. And as we know, middle fossa is composed of two main bones, sphenoid and temporal. And we're going to talk about some details. And the way I look at anatomy here is just make sure that we know every single detail that might be surgically relevant. And when we open, like for a middle fossa approach, we do not see the whole picture, but we need to be able to extrapolate everything and have a see-through image of the details and identify every single lump and bump here. So this is a basic picture of the lateral skull, and you can see that we have several lines and sutures here. So understanding those details are important. We have this blue line that basically demarcates the floor of the middle fossa. And there's been a study that basically says that the floor of the middle fossa is at the level of the zygomatic process. And as you go anteriorly, you reach the greater wing of the sphenoid, and you see a prominent spine here, which is called the sphenoid tubercle and not sphenoid spine. This is the line of attachments of deep temporal fascia. And it actually continues medially as an infratemporal crest. And we'll talk about this when we see the exocranial surface of the skull base. Basically, the middle fossa is found in this area, like anterior to the supramastoid crest. So understanding the supramastoid crest as it continues to become the superior temporal line is important. Understanding the temporal squama is one of the thinnest parts of the cranium is important. And the suture between the sphenoid bone and the squamosal bone here is important. All right. So overall, let's first define the middle fossa. Middle fossa is cradling the temporal bone, and obviously it is between the anterior and posterior fossa. I look at it like a staircase here. The first stair, the tread is here, posterior fossa, then you have the middle fossa, and then you have the anterior fossa a little bit higher than that. So posteriorly, you have the petrous ridge we'll talk about. Anterior, you have the lesser wing of the sphenoid, and laterally, you have the temporal squama. Medially, there's no specific boundary. You can draw a line, which is an arbitrary line between the tip of the interclinate process and the sphenoid, the petrous apex, which I call it petrous clinate line. And this demarcates the delineation between the middle fossa proper and the sella or the central skull base, as Dr. Dolench defines it. Now, let's look at the posterior border of the middle fossa, which is the petrous ridge. If you look at this petrous ridge, as you approach the clivus, there is this the petroclival fissure that runs between the petrous apex and the clival bone. And there is a gap here. These two bones do not attach to each other completely. And this is actually where the abducens nerve crosses over the petrous apex to get into the carotid artery. And this is the region of a venous confluence, which we call it the spheno-petroclival venous gulf, as Dr. Sami once defined. We'll talk about that later if we get some time. Let's talk about the anterior clinate process as the most medial extension of this lesser sphenoid wing, which is the anterior boundary of the middle fossa. It's like a tooth, and it's basically the medial extension of the lesser wing. The way that anterior clinate process is defined surgically is that it is attached to the body of the sphenoid bone here, and it has two main roots. One is the anterior root and one is the posterior root. So what is the anterior root of the anterior clinate process? It's basically a continuation of the lesser sphenoid wing as it merges into the planum sphenoidale. What does it do here? As it crosses this area to become the planum sphenoidale, it makes the roof of the optic canal. You can see that how it makes the roof of the optic canal. But now look at the floor of the optic canal. As the prior lecturer also mentioned, this is called the optic strut, optic pillar, or sphenoid strut. It is emanating from the body of the sphenoid superolaterally and a little bit anteriorly, and it reaches the bottom of the base of the sphenoid, the anterior climbing process. The shape of the optic strut varies. Sometimes it makes the optic canal a little bit smaller, sometimes it makes it a little bit larger. Why is it called strut? I don't know, but I can tell that the terminology, the term strut, has a specific meaning in skull base anatomy. It actually is defined for every bony island that separates an adjacent foramen from the superior orbital fissure. So look, you have the optic canal and the superior orbital fissure. So whatever goes between them is called the optic strut. Here you have the foramen rotundum that you cannot see, I will show you. And there is an island of bone that separates it from the SOF again. So this is called maxillary strut because it separates the maxillary nerve from these SOF. And that is a very important anatomical landmark in endoscopic skull base surgery. So again, the anterior root we talked about, and you can see the maxillary strut here even better. Now, bringing this into action, when we want to do anterior clienectomy, we define something that is a little bit simpler for less experienced surgeons, because we want to, what is important in anterior clienectomy is for us to know where the optic strut is, because the optic strut is the bony landmark that we have to remove to release the optic and carotid arteries from each other. So how do we figure out where the optic strut is? If you do a pretemporal approach and you start peeling the dura off, you will first identify the lateral aspect of the SOF by finding the meningorbital band. You can see it here. When you find the meningorbital band, you know that you're here. Now you continue peeling the dura off the anterior fossa floor, and you find the optic canal, and you find the medial and lateral borders of it. You draw a line between the lateral aspect of the SOF that you already found as the lateral aspect, the lateral point of the meningorbital band. You connect it with the medial aspect of the optic canal. You already have the optic canal's posterolateral end. You draw another line parallel to that. During surgery, you know that the optic strut is not going to be any anterior to this second line. So you can simply drill this area extradurally without even touching the carotid artery or being worried about the carotid artery here. And you can open the door after that. You already have detached the anterior root, and you will remove the posterior root of the optic of the anterior climbing process intradurally. This helps you drill around the carotid with more confidence while you see if there is an aneurysm there, but at the same time, you've already released the optic nerve, so that gives you some of the benefits that I have described in the paper, and I will refer you to this paper. So let's go march a little bit more laterally. Now, let's find out how these temporal and sphenoid bone come into play when we talk about a middle fossa floor. First of all, let's look at the two sutures that I've delineated. This is your the petrous bone. I'm sorry. This is the greater wing of the sphenoid, and this is the squamous part of the temporal bone, and this is the petrous part of the temporal bone. So you have three islands of bone here that are intervened by two sutures, petrous commisal suture and the sphenoid commisal suture. Remember, all the foramina of the skull base in the middle fossa go through the sphenoid bone. The petrous bone has no foramina, zero. Okay? These two sutures are important because they get to each other at around the lateral aspect of this foramen spinosum, and they make a 90-degree angle almost for each other, between each other. And this is an important triangle that we have defined before. This is called the lateral triangle of the middle fossa. And if you drill in this area lateral to the foramen spinosum, you will get into the internal maxillary artery, and you will be able to use it as a bypass donor. Now, let's talk about the foramen spinosum. This is the posterior-most and lateral-most foramen. What does it harbor? It harbors, obviously, the middle meningeal branch. It also harbors a small nervous branch, which is called the nervus spinosus, which is the recurrent meningeal branch of the V3. So the V3 goes through foraminal valley, and then it emanates a small branch that comes back to the meninges in this area and innervates them. The valley foramen is a little bit anteriorly. It might harbor an accessory middle meningeal artery. There is venous plexus basically connecting the cavernous sinus with the pterygoid plexus through all these foramina. And there is another nerve that goes here, and we will talk about it. It's called the lesser petrosal nerve. So important to understand what structures cross these foramina. Foramen rotundum is a vertically oriented foramen just underneath the SOF, and it harbors V2, obviously. And that is mostly related to the cavernous sinus, so I will not talk about it here. There are a couple more foramina that might be found. There is one is called the foramen of Arnauld, not the nerve of Arnauld, remember. And not, so we have two nerves of Arnauld. One is the greater occipital nerve. The other one is the auricular branch of the vagus nerve. But this one is called the foramen of Arnauld, or the foramen petrosum, which is just lateral. If it is there, it is just lateral to the foramen of valley. And sometimes the lesser petrosal nerve, instead of going through the foramen of valley, goes through this one. Okay. Here I have delineated two possible branches of the MMA. The MMA mainly goes laterally, superiorly, and anteriorly. This is the intercline process. When the MMA emerges from the foramen spinosum, there is one branch that goes to the cavernous sinus, but there is another more important branch that goes posteriorly. It's called the petrosal branch. It feeds and supplies the facial nerve. It goes through facial hiatus. And sometimes when you do this, if this is a major source of blood supply to the facial nerve, the patient will have facial nerve palsy. So that's unfortunate, but it could happen. You might find a small foramen which harbors the emissary vein medial to the foramen of valley, and it is called foramen vesalius. So you do not, remember the foramen spinosum is a little more posterolaterally, and this one is found more medial. Dr. Rebash talked about the lingual process in the lingual ligament. So this is the lingual process of the sphenic bone, harboring the lastrum segment of the internal carotid artery laterally, and we can talk about it later. So let's talk about some of the grooves. The most important hiatus here is the facial hiatus, and we'll talk about arcuate eminence later too. But look at the facial hiatus. Once the facial nerve gets to the labyrinthine segment, there is a sharp turn anteriorly that produces the geniculate ganglion here, and the GSPN exits the facial hiatus here, and it goes along a groove that is called the sphenopetrosal groove, but it may not always correspond with the entire length of the GSPN. GSPN actually goes on top of the carotid finally to get into the leading canal here. It is not always a complete nerve. Now, there is a groove for MMA, which I talked about. Now let's look at another landmark, which is very important, and it might be misleading. When we do a middle fossa approach and we start to elevate the dura of the temporal lobe, we want to look for the arcuate eminence, and that's the importance of understanding all these lumps and bumps. This is defined as the mid-subtemporal ridge. It's basically a ridge, is like a sierra between V2 and V3, just lateral to the two. It might be very prominent, and it might not be that prominent. But if you find something here, it is called the mid-subtemporal ridge. And usually it is very useful to find the interval between V2 and V3, even before getting the two. Okay, so right anterior to the foramen spinosum. Now let's talk about the arcuate eminence. What is arcuate eminence? The arcuate eminence, people say, hey, this is the projection of the superior semicircular canal, which is mostly true, but it basically is a combination of the pushing phenomena of the development of the superior semicircular canal, and also pneumatization of the temporal bone. So this is just anterior to the tegmen tympani, to the roof of the middle ear, and just posterior to the IAC. So this bump, which is like a mound, is not always that prominent. It's prominent in less than 90% of cases. and it might assume different shapes. Mostly, the arcuate eminence corresponds to the superior semicircular canal. And if you look at it, it is projecting anterolaterally. But look, arcuate eminence are like that, superior semicircular canal is like this. So the lateral and near the fundus of the IAC almost always correspond, but their medial end might be a little bit different from each other. There might be an angle of about 10 degrees between the two. So it is not always the exact location of the arcuate. So if you start drilling in blue line in this superior semicircular canal here, you may find it a little bit more anterior. Okay. The carotid canal is another deep canal, and this I borrowed from Anatomy Standard. Really beautiful pictures of temporal bone illustrations. And you can see this carotid canal, which runs in the petrous portion of the temporal bone, harbors the petrous ICA, a sympathetic plexus that gives up the deep petrosal nerve, and also a deep venous plexus around it. Remember, as a general rule, every artery that pierces the skull base to get into the brain is surrounded by venous plexus. Some of them are more prominent, like the cavernous sinus and the venous plexus around the vertebral artery. Some of them are less prominent, but that's a general rule. Let's look at the exocranial surface and understand the middle fossa from the other side, because this is also important. And if you look at the eustachian tube, look at this, you can see that the eustachian tube also becomes important here. This is just lateral to the carotid canal. It's a very tiny tube. Sometimes it's exaggerated in size, but it is just lateral to the carotid canal. And I will talk about it later. But overall, the exit point of the eustachian tube is just lateral to the carotid canal, where it turns into some sulcus on the exocranial surface, which is called the sulcus tubae. And then it's you will have the rest of the eustachian tube, which is cartilaginous, and it ends in the scaphoid fossa here. But look here, you have the zygomatic arch, and this is all middle fossa. You can see the foramen ovale, foramen spinosum, and this is the sphenoid spine, which is different from the sphenoid tubercle. This is also very important landmark finding in internal carotid artery endoscopically, the petrous portion of it. And all of this just lies immediately lateral to this petroclival fissure, which also harbors a venous plexus on the exocranial surface. And this is the carotid canal orifice. And you can find this petrotympanic fissure. The importance of petrotympanic fissure is that there's a nerve in it. It's called also the glissarian fissure, not Gassarian. It's called the glissarian fissure. And this is the site where the chorda tympani exits the middle ear cavity. All right, let's look at this. So you can see the petrous carotid here. We talked about the petrous ligament and petrous sphenoid ligament in the prior lecture. But you can see that how these two ligaments form a butterfly configuration. The petrolingual ligament is more ivory and is wider, and it basically separates the Gassarian ganglion from the transition of the cavernous artery from the petrous segment to the cavernous segment. So if you lift the cavernous, the fifth nerve here, you will find the ligament, and if you lift that one, you will find the carotid artery underneath. But petrous sphenoid or Gruber's ligament is something else. It is in the region of the sphenopetroclival venous gulf, and it is forming the vault of the Dorellis canal. This is borrowed from Roten. You can see how the GSPN is overlying the petrous carotid. And remember, it is not yet studied where exactly this GSPN is lying. Sometimes you find it a little bit more medial, sometimes a little bit more lateral. So do not rely just on the GSPN to see, hey, I can find the carotid artery right underneath that. And as you see, the eustachian tube runs immediately lateral to that. Petrous carotid is a very narrow cleft, and it harbors the tensor tympani, which we'll talk about. Again, one nice picture from Roten from another aspect. And you can see that this petrous canal is basically where it harbors the carotid artery before it ascends into the cavernous sinus portion. Okay. So when you look at the eustachian tube, you find two semi-canals inside it. One is the eustachian tube proper. The other one is the one that harbors the tensor tympani muscle. This is the sulcus tibiae that we talked about. This is the orifice, anterior orifice of the eustachian canal, eustachian tube when it transitions into the cartilaginous part. And there is this area which is a very tiny, thin, narrow area of bone, which is called the isthmus of the eustachian tube, and that is just anterior to the carotid frame. And we talked about the scaphoid fossa. So let's talk a little bit about the tensor tympani. Tensor tympani muscle basically originates in the lateral, in the medial wall of the and the roof of the eustachian canal. It runs posteriorly, and then it attaches to a projection on the promontory of the cochlea in the middle ear, which is called the trochlear-reform process. Some people call it the cochlear-reform process as well, which is okay because it's right on top of the cochlea here. And then its tendon makes a 90-degree turn to attach to the infus, to the handle of the infus. And you can see the fine anatomy here, how the eustachian tube is lateral to the IC. Okay. Now, cochlea is another bony structure because we're talking about the bony structures in the middle fossa here mostly. And this will be probably my last part of talk. You can see that the cochlea is part of the bony labyrinth, basically, and it has 2.5 turns to 2.75 turns. Imagine when I'm looking at you, my cochleas are like this. So the cochleas are looking inferiorly, laterally, and anteriorly. Okay, it's a very, very small structure. It's only 5 millimeters tall, and the axis again is almost perpendicular to the petrous ridge. So you want to understand this deep anatomy when you're drilling the middle fossa. You want to expose the Kawase triangle, stuff like that. You want to understand where this cochlea is. First, you have to understand the orientation of the cochlea without anything else first. So you find the petrous ridge, and you know that the orientation of the cochlear modulus angle axis is going to be almost perpendicular to that. Roten's group did a very nice study on the importance of cochlea, and you can see that also this cochlea is almost parallel to the GSPN, like almost parallel, not completely. And now we have to identify what this modulus angle or axis, what angle makes that it makes with the IAC compartment. And it's almost about like 30 to 60 degrees. Again, you can see that if you look at the cochlea, the 7th nerve wants to become, this is basically the 7th nerve getting into, this is the right side, I'm sorry, the left side. And you can see that the 7th nerve wants to make a, coming from deep side and wants to make its massive turn posteriorly and inferiorly. Once it gives rise to the GSP, geniculate ganglion, it is right between the rest of the labyrinth and the cochlea. And you can see that this part of the facial nerve is right above the stapes and right above the oval. So again, let's look at this from another perspective. You can see the facial nerve comes here, makes the labyrinthine segment, which is basically embedded and buried deeply in the bony labyrinth. It's between the cochlea again and the rest of the labyrinth. Okay. In order to get to the cochlea, you have to drill the middle fossa for about 5 millimeters or 4 millimeters. So this is called the cochlear angle, basically. That's important. This is the region of the bone that is between the IAC and carotid, and it ends up in the cochlea. How do you find this? Very difficult. How do you protect the cochlea? Very difficult. But there is a study that we did, and then there are other studies as well. I like the one that we did. And the way that we describe this to actually protect, not to find the cochlea, you don't want to expose it during surgery when you are doing it. You want to maximize your Kawase's triangle drilling. What you want to simply do is to find a medial petrous ridge, start drilling around that area. What you then find is what we call the upper dural transitional fold, which is basically a transitional fold. The first line of dura that appears, this is the dura of the IAC basically, but it is like an angle between the superior aspect of the IAC and the lateral aspect of the IAC. So you find it, and then you have the foramen spinosum and you have foramen valley. The safest way to protect the cochlea is to try to start a line from the foramen valley and make a perpendicular line to this UDTF. And then do not go any lateral to that, between that line and the GSPN. But look, that is a line from the foramen valley. If you start drilling just medial to that, you're going to be safe. But if you go any lateral to that, you're probably going to hit the cochlea here. Okay? And this is how that transition between the dura of IAC. You can see how this lateral and upper and anterior or lateral surface of the IAC looks like here. And remember, when you do the Kawase approach, which we're not talking about here, is basically mostly about the anatomy. The seventh nerve is has a very peculiar 3D relationship with the fifth nerve. It's not coming towards you. It's going posteriorly, coming from deep and going all the way back superiorly and laterally and becoming more superficial. Next is the internal auditory canal. I wanted to just say that when you say arcuate eminence and you find it, when you have an eminence, right next to it, you should have a depression. Otherwise, it wouldn't be an eminence. So this depression is called the meatal depression because it is right above the IAC, and this is the suprameatal tubercle as well. So the tubercle is right across the petrous ridge, but the depression is on the middle fossa floor. Okay? So this is the internal auditory canal. Again, in order to expose the dura here, you have to drill about 5 millimeters. Everything is in the rule of 5 almost here. But if you go laterally, will be very, very thin bone above the geniculate angle. So start drilling in this area, find the dura of the IAC, and then gradually go anteriorly, laterally. And remember that line between the foramen valley, lateral aspect, and the upper dural temporal fold here, and do not go any lateral to that to protect the cochlea. I guess that is it. Thank you.
Thank you, Professor Ali, for this excellent presentation. Is there any question from panelists?
Just to congratulate Dr. Ali, it was a very nice presentation of the bone structures, and I think it was a happy coincidence that we gave lectures together because you could pinpoint this anatomy. It's an amazing lecture, very good didactic as well. I'm sure the students learned a lot. Thank you.
Thank you very much. I stopped there. I could have gone more about the dura and everything, but I think the time constraints were enough. Thank you very much, Dr. Riba.